membrane, serum tears, their indications and outcomes depending on DUSE 3 manual that's newly come out. So amniotic membrane is a fantastic membrane. It has the capacity for anti-angiogenesis, so it stops angiogenesis. It's anti-inflammatory. It helps regeneration. It is antibacterial. It is antifibrotic. So it has everything that we need to heal a surface. So we use it in ophthalmology so much. And basic indications are the epithelial defects like we have in the dry eye, or post-infectious ulcer, or neurotrophic keratopathy, or inflammatory injury like Stevens-Johnson, or chemical burns, or post-surgical instability like post-PK. It can be reconstructive after pterygium surgery or symblepharon. It can be palliative, just to decrease the pain of the patient, like in bullous keratopathy, in a painful blind eye, and it can be adjunctive to the slat surgery that we have listened today. So it has many uses. It can be in different types. It can be the most commonly used form is the cryopreserved one. So after we prepare it, we prepare it in such a way that we can keep it at minus 80 degrees. And it has all the growth factors and the anti-inflammatory and antifibrotic activity. It's used for the acute inflammation and non-healing epithelial defects. You can lyophilize and dehydrate that so that it has a longer shelf life, but you cannot have that much of antifibrotic activity. It's much more like a mechanical support when you dehydrate it. It can be used fresh, but you can only keep it for 48 hours in the refrigerator. You have to treat with the antibiotics and then quickly use it if you cannot have minus 80 degrees refrigeration. And it can be gamma irradiated. This is further dehydrated, no cells in it. And so it is longer shelf life. And, the growth factor, there is no such a head-to-head study showing that the growth factors, trophic factors are really decreased, but this is how we are expecting it to be. Now, these two studies, there are several studies. I would like to show the outcomes of the cryopreserved amniotic membrane. These two studies show that even if we use for like 7 days, just for a week, amniotic membranes heals the surface for about 3 months' time. So this is a good time. And like 100% of them results in a decrease in staining. So they heal the surface. Even if you use it for a shorter period of time, its effect is more than that, like a month or like 3 months' time. And in like these two multi-center studies, as I said, even 2-day application results in good recovery of the surface, and it decreases the staining, and it may end up till 3 months' time. And the gamma irradiated one that we have a question mark, but it's you can easily take it. You don't have to prepare it. It's a longer shelf life, so it's available. There are studies regarding to gamma irradiated ones, and they are usually used for the dry eye. And 8 to 10 days application decreases 1/3 of the patient's symptoms, and half of them have the ocular surface reduction in the ocular surface staining. And this is also, there's a very good, nice study that dehydrated amniotic membrane just for 1 week, and you use it, and the patients are free of staining for about 3 months' time. So this is a good way of using it. What we are doing in our hospital, we don't have that Procera. We are using this feeding tube, and we publish this. And we are making a circle, and then we are suturing. These are our residents who are suturing, and they are placing this over the patient's eye. So in the intensive care units, this is very practical. The patient cannot come. So we prepare it and, put it over the patient's eye. It's zero money for our hospital. So it's very practical for those who cannot afford, or the patients cannot afford Procera. And how about the extract? Now, with high technology, we have the membrane extract. So, the preparation of the amniotic membrane, we have the placentas collected after cesarean section, then raising them and decontaminating with the antibiotics, and then freezing it, and then afterwards they are lyophilized. That means they dehydrate it and make it powder out of it. So when the patient needs to use it, it puts some water in it and shakes it, and you got the amniotic membrane extract. So this is very practical. There are several studies about that, and as you see right here, mostly they are used for dry eye, and it can be like hourly, 2 times, 6 times a day, so it differs. And usually they are previously treated with autologous serum, and usually they resolve in like 20 days or like three weeks time. The staining resolves and 100% resolves. So it's nice to have it, and it's mostly used for the dry eye treatment. So we need much more studies regarding this. There's no head-to-head study which one is better, amniotic membrane suturing or contact lens or this one. Now, coming to the blood products, there's a nice picture in the Deuce 3, I mean. When you have the whole blood and you put anticoagulation and then centrifuge it, you have the serum and the clot, and you get the autologous serum right here. But excuse me, if you don't put the anticoagulant, so this is the clot and this is the serum, so you take it. But if you put the anticoagulant, what you have is the platelets. So they are not in the clot anymore. So you have your platelets. This is the difference. And you can have the platelets if you treat it with the calcium chloride, the platelets are activated and their growth factors are released, and you can take the neutrophils out. So what I mean is that when you put the anticoagulant and you have the platelets, you have either have the platelet-rich plasma or you treat it with calcium chloride so that you degrade the platelets, take the neutrophils. Without neutrophils, you get the platelet factors plus some plasma growth factors. Let's go into the details. Now let's start with the autologous serum that you put you don't put the anticoagulation. So they have growth factors like you have seen. So they have the rich biochemical composition of natural tears, and they have some vitamins, fibronectin. They are nice for milder cases of epithelial problems, so mild to moderate dry eye syndrome kind of things. Let's see the studies like the Cochrane base. It is back to 2016. So they report that there's a short-term benefit and there's questionable function about it. So as time passes, there are several other studies come up. Like this is autologous serum versus cyclosporin in the Sjogren disease. So it's comparable in OSTI. It doesn't say that staining. It is the OSTI. It's just the patients how they feel, and they feel better. And this one is the autologous serum versus artificial tears, and it says that it is it is effective, but it is comparing it to the artificial tears. So it is better than artificial tears. It is improving OSTI and rose Bengal staining and breakup time. It may not be as effective as the amniotic membrane. Coming to the platelets, so we said that when you have the platelets, you have platelet growth factors in addition to the plasma factors. So if you have PRP, you have high concentration of platelet, but you don't have the plasma. So it's just the platelet-derived growth factors, and you have leukocytes. When you have plasma-rich growth factors, you have the content of the platelets plus the plasma, and you don't have the pro-inflammatory mediators and leukocytes. So this is a very rich, and it is devoid of pro-inflammatory action. So this is the difference. So when you use PRP in the dry eye syndrome, the patients get improved in symptoms and their staining is decreased. And when you usually they prefer it for the improvement of the neural, because the neural growth factor is in the platelets. So when you do the plasma-rich growth factors, you are much more affecting the nerve layers. So if we summarize, if there's an epithelial defect or ulcer, it is better to use amniotic membrane as a scaffold for the. Can I have the last slide? Just 20 seconds. And you can also use the amniotic autologous serum. If there is no epithelial loss, but you have epithelial defect, you can go with the autologous serum. If you have some neural problem like neuropathic keratopathy, it's better to use the platelet-activated kind of PRP or PRGF. And in the Sjögren or inflammatory condition, you may prefer to go for the leukocyte-free ones because they devoid of the inflammatory activity. I thank you for your attention.